Madam Chair and members of the board, thank you for another opportunity to provide you an update on the COVID-19 situation in Chesterfield County. Next slide. I've traditionally been providing an update on numbers. So worldwide, we're over the 5.5 million mark for total cases, with 350,000 deaths globally. The United States, there are nearly 1,700,000 cases and close to 99,000 deaths. In Virginia, we have just over 40,000 cases with almost 1,300 deaths. And in Chesterfield County, we recorded 1,263 cases with 32 deaths noted on the VDH website. 18 of those who passed away were residents of long-term care facilities, and 25 out of the 32 were individuals over the age of 65. By way of reminder, the first case reported in Virginia was on March 8th, and positive test results for the first case in Chesterfield County came back on March 11th. Next slide, please. So the good news is that we have seen a significant drop in new cases in long-term care facilities and correctional facilities. I think this can be attributed largely to three things. First, an improved supply of personal protective equipment to long-term care facilities, though there are still reports of inadequate supply chains to some. Secondly, improved infection control practices, either done proactively or in response to cases in facilities. And thirdly, an increased testing being done in facilities, either full-scale point prevalence surveys, which test everyone in a facility, or more focused testing. Both help inform infection control practices. Over the past few weeks, most of the cases we've noted have been due primarily to community spread. Next slide, please. So we've been seeing a steady increase in case numbers over time. The dark red line on the graph is the 7-day rolling average of new daily case numbers, which is superimposed over a plot in green of the number of new cases per day since the middle of March. This increase can partly be attributed to increases in testing conducted in the county, some of which has been through fairly large-scale community events over the past 2 weeks. The health department tested 304 individuals since March 13th. In addition to this, there have been several large-scale community testing events in neighboring health districts since early May, where Chesterfield County residents have been tested. Next slide, please. So these two graphs are taken from the VDH website and provide information about testing at the health district level. Both graphs on the right show the number of tests being conducted each day since mid-March in the Chesterfield Health District. So both graphs are actually identical. Yellow lines, however, on each show something different. For the top graph, the yellow line indicates the rolling average of tests conducted by day, showing an increasing testing capacity in this district over time. There have been just over 11,000 tests conducted in the district to date, which is the fourth highest number in the Commonwealth. The graph on the bottom shows something different. Here, the yellow line indicates the 7-day moving average in the percent positivity of test results, showing a high of around 28% of the test results coming back positive in mid-April, when testing capacity was extremely low, to a decline through the end of April and early May as testing became more available. The lower the value of percent positivity, the better. The goal is less than 10%. Even though we've been testing more in May, we've been seeing an increase in the percentage of these tests that come back positive, which is reflected in an upward trend in percent positivity. Higher percent positivity can indicate that not enough testing is being conducted to identify all the infected individuals in the community. Again, part of this could be due to the relatively recent increases in testing, which has found more positive individuals who otherwise didn't have access to testing. We want to get to a point where there's consistently high levels of testing so that positive individuals can be identified earlier, leading to a downward trend in the percent positivity rate. The Chesterfield Health District is at 17.5%, up from 11.8% 3 weeks ago. Next slide, please. So without a vaccine, containing the spread of an infectious disease like COVID-19 requires separating those who have the virus from those who don't. Here are the 4 main components of the strategy on this slide. So with regard to testing, the top left, there are continuing efforts to make it more widely available through three primary approaches. The first of this is community testing. The health department, in partnership with the county, is providing community testing to vulnerable populations, specifically those who are under or uninsured. Secondly, increased private sector testing, which has shown improvement over time. VDH at the state level is availability through primary care providers, urgent care centers, and other venues, including businesses. And thirdly, increased public sector testing. VDH has been making overtures to free clinics and federally qualified health centers to provide consistent testing to under and uninsured populations that would be consistent over time. With respect to the three other steps indicated, isolate, find, and quarantine, case identification and contact tracing is key to containment once testing identifies positive individuals. Again, the goal is to separate those who are sick from those who are well. VDH is hiring contract staff to assist health districts with identifying cases and then locating and speaking with contacts to those cases. This contact tracing is important to isolate individuals who have been exposed and potentially at risk of becoming infectious from spreading the virus to others. All of this work is extremely labor intensive. We're hoping to have all additional staff onboarded within the next 6 weeks. Next slide, please. We conducted 4 community testing events since May 13th, working again in partnership with County Fire, EMS, and Public Safety, in parts of the county with higher socioeconomic vulnerability. The focus has been to provide testing to those who are underinsured or uninsured. Telephone registration is preferred, but there is some testing available for walk-ups. Neighborhoods where we plan to conduct testing receive coordinated outreach through multiple agencies in advance. Here's a list of upcoming community testing events. Next slide, please. So in closing, I'll provide the phone numbers that county residents can call if they have COVID-19 related questions. At this point, I'm happy to answer any questions you might have.
Any board members have any questions?
Madam Chair, I've got a couple questions. Dr. Samuel, one of the things we've heard about is the possibility of a resurgence or a second wave in the fall. Wondering if you agree with that assessment.
Yeah, I think time will tell in so many things, Mr. Winslow. The prediction, I think, is premised a lot on the fact that with cold and flu season, individuals, of course, will be confined. And until we have any sort of adequate protection measure like a vaccine, it is indeed very possible.
You mentioned the vaccines, and I've certainly been trying to follow this. My understanding is that the virus has mutated 14 times across the globe that scientists are aware of, and that 12 of those mutations are currently in the United States. Just wondering, do you see this vaccine as a real possibility? Or do you think that this virus will mutate and burn itself out? Just wondering what your thoughts are. Seems everything I've read indicates that the virus is mutating slowly, but I'm not sure what they're comparing that, against, what viruses they're comparing that mutation rate against.
Right. Yeah, coronaviruses in general do mutate, and I'm afraid I'm not up on the kind of latest scientific literature. So, even with respect to cold viruses, many of which are coronaviruses, we do see those mutations. With regard to a vaccine, I think there are efforts to target portions of the virus that typically don't mutate, and I think that's generally the approach when ideal vaccines are being developed and constructed. Again, I can't speak to that with any degree of certainty or expertise, I'm afraid.
Knowing what we know now after this first wave, what sort of things are you thinking in terms of if we have a second wave, What changes do you think are in order for our locality and the localities in the health district?
Yeah, that's a really good question. I trust that we won't have to go to extreme social distancing measures, but I do believe that the new normal, at least for the near term, is to be practicing what many are doing right now, which even inside of buildings are wearing face masks and keeping that six foot range. So I think in kind of large measure, there will be behavioral changes that will have to be kind of integrated into our normal activities. Beyond that, a lot of it will sort of depend on trends as we kind of progress through the summer with regard to wider scale opening. I'm thinking educational institutions and so forth. So it's a wait and see game, I'm afraid.
Well, you touched on as my last question. The question I'm getting mostly from citizens in Clover Hill is, sort of predict what's going to happen in the fall, where the families are trying to plan for their fall. What do you care to offer any prediction as to whether or not we'll be attending regular public school in the fall?
Yeah, that's a really good question as well. As these phases unfold, I think that's going to be kind of the true measure, and certainly monitoring case rate responses will be critical to that. There are a number of different indicators that are being watched, and I don't know what are specific to school-based decisions, but beyond that, again, I think it is a wait and see game.
Thank you, Dr. Samuel.